Recovery and Resilience series was designed to help us ask and address hard questions, and also to help identify and promote solutions for the HIV community as we all grapple together with this new pandemic. Questions like, how do we maintain our health? How do we maintain services? How do we maintain connectivity in an increasingly virtual and isolating world? And most of all, how do we find and create resilience together? Today, we're going to focus on the increasingly important issue of aging with HIV, which is especially critical in light of COVID-19's impact on people with underlying health conditions and those who are advancing in age. Those of us like me who are living with HIV, who are 50 years old and older, and all long-term HIV survivors of any age who have been living with HIV for at least 20 years, all of us face considerable challenges and even barriers to our health and well-being. We know that approximately 50% of all individuals living with HIV in the US are over the age of 50 already, and it's estimated that by 2030, that number will increase to 70% or more. But along with everyone else today, older adults living with HIV and all long-term survivors with HIV face new and even unique challenges created by the novel coronavirus, not the least of which are the challenges of being isolated, being stigmatized, ignored, neglected, and even forgotten. And the risk of possible infection from COVID-19 affects not only us, but HIV service providers and healthcare providers as well. Older adults living with HIV and long-term HIV survivors of any age, regardless of how or when we acquired HIV, have all learned. We have all learned how to survive. We've dealt with changes in medications, with changes in laws and access to care, and now the changes created by COVID. But the HIV community can use the lessons we have learned from our nearly 40 years of experience with HIV to deal with this new environment that COVID-19 creates. We know that we can overcome fear and anxiety. We can transcend policies and even politics, and that's because we are resilient. But the HIV community knows well that the road to resilience begins with knowledge and open discussion in community. And that's what we're doing today through our webinar series. We hope today's AIDS United webinar and our discussion will be a step forward in our recovery and gaining resilience for all people living with HIV and all of us aging with HIV in this new COVID-19 world. So now we will begin, and it's my pleasure to introduce our moderator for today. She is one of my favorite people in the movement, Dr. Dazon Dixon Diallo. Dazon is the founder and the president of SisterLove, a global organization with a mission of eradicating the adverse impact on women from HIV and other reproductive health challenges and injustices. SisterLove is thriving for over 30 years from its offices in Georgia and South Africa, and its success is because Dazon is a visionary leader, a tireless advocate, and a brilliant strategist. She's the co-chair of the Act Now End AIDS Coalition, and SisterLove is one of the newest members of the AIDS United Public Policy Council. And I happen to know that she's Dr. Dazon because she has an honorary degree. So Dazon, thank you for joining us to moderate today. We look thrilled to have you, and please take it from here.
Well, Jesse, it does not intimidate me to follow you, only because I have had to do it so many times I've gotten used to it. And I really am grateful for the invitation to lead this conversation today and to learn from this conversation today. I'm super excited about it. I will not take that much time because I would much rather hear from our illustrious panel that we have today. I do want to remind folks a couple of things. One, and you'll hear it come through in maybe a couple of my questions as we get through. I like to think expansively, intersectionally, intergenerationally, and interconnectedly as often as possible. And so when we were organizing and talking about this, we talked about expansion of our notion and our thinking in the language that we use around aging and what that means, because quite frankly, every single thing alive starts aging the moment it becomes alive. And that includes people who are born living with HIV, who have also been aging into and will continue to. So I'm going to probably refer to this conversation more about HIV and older adults, so that we are able to distinguish and recognize that we are honing in and prioritizing a population amongst many who have had long-term challenges and even physical, mental, and other issues related to living long with HIV and having other comorbidities and challenges happening. So that's the first thing, and that's just how I bring myself to this. I also want to remind us and be very grateful and show our love for Laura Castro and Jose Manuel Verano of Your Next Solution, which is providing simultaneous Spanish translation. So reminding our speakers to, and I have to remind myself, to use your slower voice. Even if I'm from the South, I can talk pretty fast. And so I have to remember to slow that down. But also, if you are in need of language interpretation, there is a button that you can click that says interpretation. And it has an icon of a globe that's below in order to access your translation needs. And also, if you have any questions or comments for our panelists, please put those in the Q&A function so that we can follow up and provide those questions at the end of our presentation. So in the order of how our panelists appear on the screen, we're going to ask the parents, you see how many conversations I've been in today? Panelists to introduce yourselves by your name, your pronouns that are preferred, and the organization. And of course, then we'll go into the rest of our talk. And so we're going to have people introduce themselves very briefly in that manner. So in the order of how you appear, it's sort of like a box here, and I'm going to do what I always do, which is go to the left first. And so I'm just going to call you by name based on what I see in the boxes, because your box might look different from mine. So I'm calling Carole Treston.
Hi, I think I just unmuted. Can you hear now?
We can hear you great, Carole.
Great.
Thank you.
Hi, everyone. Thank you for inviting me. My name's Carole Treston. I'm a nurse. I've been a nurse working in HIV for many years, probably 30 plus years. I'm so thrilled to be the executive director of the Association of Nurses in AIDS Care. I think most of you know our organization, representing nurses across the globe involved in HIV and comorbidities. It's great to be here. Thank you for inviting me.
Thank you. I'm going to keep going counterclockwise because we're in a counter resistance moment anyway. So let's go to Ronald Johnson. Just introduce yourself, please, Ronald.
Hi, everyone, and thank you, Dazon. My name is Ronald Johnson. I am retired and serving as a senior policy fellow at AIDS United. I also am a member of the U.S. People Living with HIV Caucus, serving on as chair of the steering committee, and I am an older adult living with HIV.
Thank you, Ronald. And I just want to say, if this is what retirement looks like, I want to see what your rest looks like, because that's insane. I have seen you working so hard, like you never left the scene. So I'm glad you're still here and feeling as if you're retired, but we know different. Venita.
Hey, good afternoon, everybody. Yeah, it is a pleasure to be here. My name is Venita Ray. My pronouns are she, her, and hers. I am currently the Deputy Director of the Positive Women's Network. I wear a few other hats, being part of the U.S. People Living with HIV Caucus, HIV Racial Justice Now, and a group called Black South Rising. I was so surprised. I can identify as a person, an older person living with HIV. I'm not sure when I got that title, but I have it. So thanks for having me.
Thank you, Venita. And of course, we would like to keep moving. And Stephen Karpiak, hi. Introduce yourself, Stephen.
Hi, this is Steve Karpiak. I'm the Senior Director for Research at the GMHC, and I have been conducting research on this population, the older HIV population, since 2002, longer than I want to recognize. But we are in a unique place these days, which COVID has kind of re-emphasized because of a lot of the ageism that's associated with it, and also the impact on older adults living with HIV. So I look forward to a good discussion and some new information. Thanks.
Great, thank you so very much. And thanks to everyone for joining in and for participating in this conversation today. I want to start it off with Ronald Johnson because, you know, as we say, and my parents, who are both educators, have always said that, you know, if it ain't written, because my daddy says you can do anything if you can read. So if it's not written, it necessarily didn't happen in the universe that we live in, especially in these contexts. We have to tell our stories, and we have to be the ones to tell our stories, those who are living the experience. And if I could quote Congresswoman Ayanna Pressley, who consistently uses the mantra that those who are closest to the pain must be closest to the power. And I think it is important in terms of what Ronald Johnson is releasing in terms of this really powerful paper that speaks with a voice of experience and lived experience, as well as the research and the intelligence of the experience on HIV, getting older, and looking at it through the lens of COVID-19. So Ronald, you go ahead and take the mic, please, and talk with us about your paper, as well as bring your remarks for this panel. And thank you so very much again for joining us.
Thank you, Dazon. And again, welcome everyone. And I'm really honored to be a part of today's webinar. To begin our discussion, I want to give a quick report on AIDS United's policy and advocacy work on HIV and aging. And as Dazon said, that work is going to be detailed in a paper that will be released today and will be posted on AIDS United's website. We began our work with a series of listening sessions held in 12 cities across the country, including San Juan in Puerto Rico. And we also had a session at AIDS Watch 2019 and 2 sessions at USCA. And the purpose of those sessions were to hear directly from older adults living with HIV, their experiences. Next. What we heard, and it's not surprisingly much of what we heard is what we have heard before, but it was very important to hear it again and to see the difficulties and to hear some of the difficulties that people are experiencing as they age with HIV. And not surprisingly, much of the issues dealt with healthcare and the difficulties in managing healthcare, particularly when you're also managing comorbidities, diabetes, cardiovascular care, frailty, all of these comorbidities that older adults with living with HIV are vulnerable to. And also the various pharmacy issues, polypharmacy issues, and gaps in healthcare workers' knowledge. Healthcare specialists that don't know much about or don't connect with comorbidities, non-HIV related comorbidities, and geriatric and other non-HIV specialists who really don't connect with what the impact of HIV has on older adults living with HIV, and concerns about long-term care. Next. Again, not surprisingly, there were concerns about mental health and alcohol abuse, but an overriding issue was dealing with the various social issues: loneliness, social isolation, inadequate housing, and concerns about what's going to happen when we, quote unquote, end the epidemic. And I want to quote, as you see on the screen, one person who said, support services are dissolving. And that's a key issue that older adults dealing with and living with HIV feel. That support services, even some of the ones that we started in the very beginning of this epidemic, are not as prominent today as they need to be for older adults. Next slide. And some of the key observations that we heard from the listening sessions, and I want to note and really highlight that the current group of older adults, and by that I mean people living with HIV who were born or before or in 1970, the youngest of whom will turn 50 this year, that we represent the first cohort of adults and people aging with HIV. And we're sort of almost a natural experiment of what it means to age with HIV. The listening sessions provided strong verification of concerns and issues. Again, we didn't hear anything new, but the fact that we heard it again and again is very, very significant. And we need to acknowledge that many of the concerns of older adults living with HIV are common to all older adults and are common to all people living with HIV, including long-term survivors who are younger than 50. But also what is really important for today's discussion also is that participants in all of the listening sessions demonstrated the resilience of older adults living with HIV. Next slide. Also, it was really very apparent from working on this that we currently know a great deal about HIV and aging and about the needs of older adults. There's a lot we still need to know and are learning, but we already know a lot about HIV and aging. And there are many programs that are serving older adults living with HIV. Many of the sites of the listening sessions were with providers and who had programs of dealing with and supporting older adults living with HIV. Also, there are many government officials and policymakers who are currently focusing on HIV and aging. However, there is still an issue that too many older adults living with HIV feel that their needs and concerns are given less attention and ignored. And Tez Anderson highlighted this when he said that we who are older and living with HIV are a forgotten majority. Next slide. And this really has highlighted for us as we were dealing with these issues, the disconnect between what is known about HIV and aging and the reality that not enough is being done. The reality that although there are programs, there are government officials who are beginning to pay attention to older adults and HIV and aging, there is still the reality that older adults living with HIV too often feel neglected and ignored. And we see this as the need, highlighting the need for sustained, focused, and collaborative advocacy to make that disconnect disappear. The priorities of that, the goals of that sustained advocacy is really the inclusion of issues directly targeting HIV in all the broader response to HIV and efforts to end the HIV epidemic. Similarly, we also need a greater mainstreaming of HIV care and prevention in all services for older adults. That HIV care should be a routine component of services for all older adults, and services for older adults and long-term survivors should be an integral part of HIV care. Next slide. Some of the priorities of this sustained advocacy, certainly medical care, mental health issues, housing, transportation, and support services. We need to build back the support services that has really been reduced over the past few years. We need to address stigma and discrimination, and we need to make sure that services that target older adults are not forgotten as we move towards ending the HIV epidemic, and that ending the epidemic does not mean the end of services for all people, particularly those of us who have aged and continue to age with HIV, and the intersection of HIV policy with older adult policy in general. Next slide. And we want to move towards that vision where all people living with HIV will receive the care and support needed to age successfully, having achieved and maintained good physical and mental well-being. As one person in this listening session said, we want to live a positive, healthy, free life. Next slide. But as with so much today, HIV advocacy and advocacy for older adults living with HIV is turned upside down by the SARS-CoV-2 epidemic, and which has changed nearly all of the landscapes in which we live, including the response to HIV. As Peter Piot said in his keynote address last week at the closing session of AIDS 2020, COVID-19 has changed the world, and we need to take that into consideration. I don't think anyone needs to be reminded that SARS-CoV-2 infection is rising in the United States at the moment. We're experiencing a surge. This nearly 1 out of every 100 may already have changed from Monday when I quoted that. Next slide. And this fact that COVID-19 and SARS-CoV-2 infection is so endemic in the world today was reflected last week in the AIDS 2020 conference and the COVID-19 conference that was held last Friday. And some of the things that were reported at the conference, some of the studies have generally found that people with HIV are no more likely to track the novel coronavirus than their HIV negative counterparts. And they generally do not develop severe illness or have a higher risk of death. These were studies from New York and other areas that were reported at the conference. But certainly it was said consistently that we need more research on the interaction between HIV and the coronavirus and COVID-19. Next slide. But it was also clear at the conference, and what we know and our experiences over the past 6 months with this epidemic, that the social determinants of health and underlying medical conditions can and do impact the vulnerability of people living with HIV, including older adults. Racism, homophobia, social and economic injustice, these are issues that heighten vulnerability for COVID-19 and also, as we well know, heighten vulnerability to HIV. And the comorbidities that impact COVID-19 are also the comorbidities that impact older adults aging with HIV. So these are issues that heighten the vulnerability of older adults living with HIV. And also it was pointed out that COVID-19 has interrupted the care and treatment of chronic conditions, including HIV. And that global 2020 targets are being driven further off track by COVID-19. But we had strong reminders that the response to and advocacy on COVID-19 can and should be informed by HIV response, advocacy, and activism. The history of HIV activism can be a model and should be a model for the kind of advocacy that we need with COVID-19. Next slide. And an important point that was made at the conference is that we need to pivot from anxiety to self-efficacy. And that will be very important as we move forward. And that is really much the theme for today's discussion of how we can use our selves and the efficacy that we have to deal with COVID-19 in the context of HIV and HIV in the context of COVID-19. So I'm really excited that this next part of the webinar and the presentations and the discussions will help us move from anxiety to self-efficacy as we deal with aging with HIV and also COVID-19. So Dazon, I turn it back to you to introduce our panel discussion.
Thank you, Ronald. That was fantastic. I do have a couple of questions. I'm waiting to see if there are any. Let me check and see if we have any questions in our chat box. We do have a couple of comments from folks who are responding in terms of, or at least from one person who is expressing their current experience, especially as someone who's been living with HIV since the 80s, since 1986, and wasn't able to work for a very, very long time. And after getting back into work, COVID changed all of that. And so it's sort of looking at what strategies that they have to return to work as soon as knowing that the antibody tests are accurate. So that was a comment, not necessarily a question, unless you wanted to respond to that. I do have one that I think when you were talking about the service delivery and the workforce and accessing programs that actually are responsive to and are user-friendly, if you will, and conscious about the specific and unique needs of our older populations or people living with HIV who happen to be older. What is your thought and what have you seen in terms of what the preparations are for the intergenerational dynamics in the workforce, that we have been accustomed to having a peer-based model, even for those who are getting older living with HIV? For the most part, usually the people who were in the service context of it were also in their age groups. And now as older people reach retirement, so except for you, as older people reach retirement, that there's also a younger workforce coming. How are we dealing with those intergenerational dynamics between older people accepting the new ways or the new emphasis of younger people's engagement in the workforce, being their caregivers, maybe 20 years younger or somewhere in there, and the likewise the younger generation in terms of its preparedness in respecting, loving, and taking care of their older patients.
Do you want me to start that discussion, Dazon?
I just want you to give a couple of seconds of thought on that, just to.
Yeah, I think that is a critical issue. And there are two aspects of that. First, as you noted, much of the workforce that we have today is aging themselves and getting the point of retirement. And I think while there are instances, in many cases, several instances of that kind of intergenerational training, mentoring, or whatever phrase we want to use, but it is not enough and it is not systematic. And I think that's one of the issues when we say we need sustained advocacy to end those disconnects, is that we need a more concentrated, a more deliberate approach to that kind of intergenerational training, because we need training for the workforce. I mean, a real concern is the shrinking workforce, particularly devoted and concentrated on HIV in general. So we need reinvigorated training. We need that training needs to be deliberate about using the knowledge and experience of older workers to help train and mentor the younger workforce that we so desperately need.
Thank you. And there are questions coming in, and we're going to get to as many of them as we can before the end of our session, but I'm going to quickly move forward with our next presenter. And also recognizing that, at least I want to share with you, there are comments coming in saying that there are similar workforce concerns going on in Australia. So we are not alone in this domestic context, and we have to remember that, especially in this beautiful virtual space that we're holding these conversations and gatherings. Next up, I want to bring to the mic Carole Treston, Executive Director, AIDS Association of Nurses in AIDS Care. Carole, take it away.
Hi, Dazon, thank you. So I think you'll hear a lot of the same themes repeated in our talks today, maybe just from different perspectives. But for me, COVID-19 has laid bare many factors that we as HIV advocates have been calling out before COVID-19 in relation to HIV acquisition and outcomes. Factors like social determinants, racial disparities in outcomes, the intersections between mental health and substance abuse, and a need for person-centered healthcare. And now the spotlight really is showing on our poor investment in the United States, at least, and I would say probably in other places too, in the elder, and I'm going to try to be correct, Dazon, in the elder population in the US. So what does all this mean from a nursing and clinical perspective? And I'm going to talk for a few minutes about that. So one of the things that's for sure is we are learning a lot more about this disease, COVID-19, every week. And that's just a point of fact that people need to get comfortable with. And because that uncertainty and that changing knowledge actually leads to a lot of uncertainty and anxiety, right? And so I think that's just a moment where we have to stop and say, okay, we are learning in 5 months what we learned about other diseases in five years or even 5 decades. And that what's something new that comes out this week doesn't necessarily mean that what we knew 2 months ago was wrong, is what we knew at that time, right? So that uncertainty and that constantly evolving information certainly leads to anxiety. And I think that we all have to find a place of acceptance around that in this rapidly evolving information. But one thing that we pretty much are certain of is that people living with HIV, it does not appear to impact people with HIV more than anyone else. But what is of concern is certain underlying conditions that people aging, living with older people living with HIV may have these certain conditions such as heart disease, renal disease, chronic obstructive pulmonary disease, obesity, sickle cell, and organ transplant. They are the top co-occurring conditions in serious illnesses and hospitalizations. You can get this now on the CDC website, which tracks all of this information. Now, is that going to be in place after the new directive where the CDC is no longer getting hospital information? We don't know. But we do know that about that second tier of potential illnesses, there's limited information on, and it may indicate some more serious conditions. HIV without intact immune systems is in that bottom list. But so are things like pregnancy, smoking. So again, it's important for us to understand, what do we know now? There's this list of 6 or 7 serious comorbidities that people living with HIV, if you have one of those comorbidities, that would be a concern. But if you are in that other group, you probably are much more similar to someone who may have some health conditions, but nothing like those that I described. And of course, it's whether these conditions are treated and under control or not so much. But we do know that easy access to consistent, reliable, trustworthy healthcare and a provider that cares about you as a person and knows you as a person, right? Not a revolving door of part-time rotating staff. That really makes a difference in chronic conditions. And also some of the underlying factors in these underlying conditions are the same as some of the underlying factors and social determinants related to HIV. And what are these? Well, poverty is the simplest answer, but let's dig a little deeper in some specific examples there. Food scarcity. and poor options. I'm not saying poor choices. There's a difference, right, between poor choices and poor options. But poor options when the only food that's available in your neighborhood is from fast food joints or bodegas where they, sell Vienna sausages and chips. And this is some of the underlying reasons why certain communities might have more common conditions like heart disease, obesity, diabetes, right? Let's dig a little deeper about why are these, what does this mean? So social determinants mean in a very basic way, that's a big word, but it means in a very basic way, for example, how cigarettes are advertised more in poor neighborhoods and how the rate of smoking and therefore things like chronic obstructive lung disease and cardiovascular disease are more predominant in certain neighborhoods. So, we all have to think back about these things now are becoming more apparent to the larger population. Those of us who have worked in HIV and advocacy for years have been screaming about this, right? And so that may be a silver lining of the COVID pandemic, is that more people are becoming aware of things that have been critical to those of us who have worked in HIV advocacy for years. So what does this mean for people who are living with HIV and older people who are living with HIV? Well, the first thing is stay in care, right? And we heard a little bit from Ronald about some of the impacts on people losing access to care because they're afraid to go out. Maybe their clinics are closed, maybe they're only using telehealth, but figure out a way to stay in care. Talk with your Ryan White provider, call them, call your case manager. Maybe now is the time to think about adding a gerontologist, requesting a gerontologist to your team. Really think about some of the things that you can control. I love what Ronald said about we now need to pivot from anxiety to self-efficacy, right? So how can we control healthier living to reduce our risk? So whether that's thinking about our diet, whether that's thinking about smoking cessation, maybe now is the time to talk to your nurse to cut down harm reduction, talk to your nurse at clinic about smoking cessation. Again, don't drop out of care. Will telehealth work for you? For some people it may, for some people it won't. Phone calls still work, right? And go to clinic. I think, again, let's reduce that anxiety. By now, most of us have learned about how to operate safely. So clinics space out visits. They space out how many people can come in. Mask up, wash your hands, avoid crowds, but don't avoid care. The other thing I like to say is go for a walk, right? How do we manage anxiety? Get outside, get some sunshine, get some vitamin D, and wash your hands. But the real onus of responsibility is on us as providers. We must really be our patients' advocates to ensure that the systems that we work in work for our patients. Telehealth is a great option. It's not the right option for everyone. Some of the nurses that are part of our organization are now going back to, I think Ronald talked about some of the old things that worked, are now going back to home visits, right? If people can't get into clinic. So it's important to stay connected. And providers really need to practice extra kindness in a clinic setting and reach out and care for somebody. But the impact of social and physical distancing on loneliness and social isolation can't be understated. It's certainly experienced to high levels by people aging with HIV, and now with COVID-19, it's exacerbated. It's exacerbated for all of us, right? But even more so for people who are already starting at a baseline of social isolation. So what are some coping strategies and how to mitigate that? Again, let's think about evidence-based self-efficacy and not living in fear and anxiety. So if it works, Zoom calls like this, online excursions to a museum, that may work for some, it may not. Regular phone calls. I know a number of people, Tez Anderson being one, who now makes it a point that every day he makes a 10-minute phone call to somebody he's been meaning to touch base with, right? So it's a good opportunity to go back to some basics. Go out for a walk, sit on a bench, keep a routine, monitor, and be careful. I gotta laugh at this because I'm in that boat. Monitor your drinking. There's been an explosion of wine consumption during the COVID. Oh, my time. And monitor substance use. This this is not a fun time, right? But we can get through it. We can get through it with self-efficacy and self-care techniques. And then finally, in closing, I just want to say one thing about advocacy here. One of the things that's really become clear to me is that now is the time for us to be part of a bigger advocacy world. Concerns about poverty, racism, ageism, public health, science versus politics, living wage, food, security, etc. That impacts us all, not just people living and aging with HIV. And the COVID-19 pandemic has really shown that. In my opinion, now is the time for us to be a bigger part of the big tent advocacy, right? Rather than siloed advocacy. Looking at the root causes of all of this, the root causes of poverty and other chronic conditions. So there's a lot of things that we could get involved with that are outside of HIV, but benefit people living with HIV, such as the Older Americans Act, the CARES Act, SNAP programs, other things. I'm going to close there because I'm running out of time, but I do want to just point out that the COVID-19 pandemic has really shined a light on the disparities and the inequities in our society, things that we in the HIV world have been calling out for years, but hopefully now others are more aware of and will also join in the fight. Thank you.
And thank you, Carole. I very much appreciate those comments. And we do have more questions that we'll get to, but I want to get through our panelists' remarks and then we'll follow up with some more questions. So let's keep moving. Thanks again to Ronald and Carole. I want to move next to Stephen. Stephen Karpiak, please take the mic.
Thank you. I must say, as I mentioned before, I've been doing this work since 2002. And I believe I know a great deal about this aging population, but I'm still learning every day. And my hat is off to Ron for giving really an extraordinary summary of where we're at. There's so many parts to this issue of HIV and aging. And it's not one simple one, if you will, or direct one, but it's multiple, which makes the challenges even larger. Our two panelists have already covered a lot of territory. So what I'm going to try to do is just give you some observations from where I sit. I began research on the older adult back in 2003-04. We studied 1,000 people in New York City who were older adults, and more recently completed 5 sites study in San Francisco, Oakland, Chicago, upstate New York, rural, and New York City, looking at a sample of approximately 2,000 older adults. And there's certain things that impact me, having looked at this population for so long and now listening to them. I must say, one of the great lessons of life for me as a researcher is, yes, I read the literature, yes, I love numbers, but the most compelling information comes from the peer, the client, the person living with HIV more than anything else. And to emphasize that, one of the things that we heard in many focus groups across this country was the statement, there are things worse than AIDS, like loneliness. So loneliness goes along with depression, and one of my observations in this population is that they have been ill-served when it comes to mental health. The rates of depression alone and anxiety are 3 to 5 times higher than in age-matched groups in the larger society. I was a professor in psychiatry at Columbia University for 25 years. Depression is eminently treatable and manageable, and to think otherwise is to think wrong. I think we need to put more emphasis on mental health, not just for this population, but has been mentioned for many. Mental health is the key, one of the keys to successful aging for this population. We cannot minimize it. There are many ways to intervene for depression, especially, be it medication, verbal therapy, or group therapy. A great deal of it has to do with the fact that social isolation drives this depression on a daily basis in this population. We've got to be able to break that lock. One of the other, Ron referred to this, one of the really emotional moments in my life is to sit among a group of long-term survivors or older adults and to hear the words, "You abandoned me." You know, abandonment is one of the most powerful emotions. Think of a young child who's lost in the shopping center, or when someone has ended a relationship and you feel abandoned, or upon death. This is a very, very powerful emotion. And I hear it over and over and over again from older adults. And we need to change that. And the only way we can change that is to be responsive to them, particularly the AIDS service organizations. In so many ways, ASOs were built on the shoulders of this cohort. And we have abandoned them. And how to connect them to services, existing services, particularly within the ACL of the government, but also what services do they need? And in some respects, I must tell you, I look at people who work in the aging domain. They're the ones who have the answers here. People in HIV really don't. You know, aging has a long history, a long knowledge base. There are so many agencies within every community that we listen to today. They have dealt with aging without HIV. Well, we're much in the same place. How do you deal with social isolation? How do you deal with managing services? How do you deal with being homebound, et cetera, et cetera? Aging folks, if you will, have always known answers or have at least a beginning for those answers. And we need to turn to them, not to other people who work in the HIV field only, but to people who actually have in-depth experience in aging. And that includes the ACL from our government. In that context, some of the observations I made recently because of COVID was that we had, like at GMHC, we have a major commitment to the older adult, and there's more to come. But we have 5 programs that were aimed at the older adult. And yet all of a sudden, the programs were gone in a way that we no longer could meet face-to-face. So we had to port them to either Zoom or Adobe platform. And there was a lot of hesitation in doing that. And yet what we found out was that, one, more people come to those platforms than they did in face-to-face, which kind of makes sense if you're older. Even in New York City, we have great mass transit, but it's still a chore. And the amount of interaction, the amount of questions, the amount of queries that we get from that platform rather than face-to-face is clearly obvious. I don't have to run a t-test to figure that one out. So it says something to us. COVID is speaking to us and saying, you know, maybe we have to think about the modalities of how we transfer information to this population. One of the modalities, or one of the areas of information that is so much in need is really how to manage multimorbidity, and of which HIV is only but one of those chronic conditions. And perhaps the easiest one to tackle compared to cardiovascular disease, cancer, kidney disorder, the list goes on and on and on. We need a different approach. And as was mentioned, the workforce is shifting radically. Now, I'm very fortunate to be a member of the Rockefeller Einstein CFAR here in New York City. And I'm surrounded by young physicians who want to treat people with HIV. Well, they're not staying in this country, they're going to Africa. Because treating HIV has become, in some respects, not easy, but a more direct approach. So the same things happen to our present primary care physicians who are treating those with HIV, our ID docs. They are, you know, not that they're no longer needed, but they're very shifty into treating other conditions. 10 years ago in New York City, for example, 80% of the time of the primary care physician was spent working on HIV. Today, it's the exact opposite. They spend about 20% of their time with the older adult and on HIV, and the other 80% on all the other conditions we hear about. This is a very complicated challenge, not only on the medical level, but also, as we've heard, on the social, psychosocial level. There is a need to integrate care at every single level. This happens at major teaching hospitals to a certain extent, but it does not happen in standalone clinics. One hand doesn't know what the other is doing. I have met many, many, many clients who tell me, oh, Steve, I'm taking XYZ pills, and they suddenly rattle off 15 prescriptions. I'm not joking. And I'm like, really? This is an issue of polypharmacy. So what happens is a primary care refers people out to a rheumatologist or to a cardiac specialist or whatever, and they don't talk to each other. And I think this is where, for example, nursing is needed desperately. We need someone with clinical background to coordinate care, to avoid polypharmacy. There are so many drugs people are taking that we don't even understand the interactions. And on top of that, all the things people take from OTC, over the counter. I ask people, why are you taking that drug? And, well, I read it in the TV guide, or my grandmother told me. It's not a reason to put anything in your mouth except food. So it's a very, very much more complicated situation that we're entering clinically, but also socially. This is a population that's been socially distanced for many, many years. They are in care, And even though they're dominated by African American and Latinx populations, they're actually doing rather well, as we know from the new evidence coming out. Ron pointed this out, that the risks, which were considered very high in the beginning of the COVID epidemic, have now been modified. There are still risks there, and they're considerable, but we need to pay attention to what they are specifically and not panic. Too often that happens at the beginning of any particular new information being released. I also think that COVID has exposed ageism. You know, we all talk about HIV/AIDS stigma. In fact, I think we talk about it too long because I haven't yet to see one budge in it and one nick in it at all. It's so hard once you internalize the stigma that surrounds you, and certainly people with HIV have. But also ageism. Ageism is the stigma that we accept in society, particularly in the United States. I often wonder, you know, HIV older adults dominate the HIV epidemic in this country. They account for 60% of the 1.2 million people living with this virus. Why don't they have a bigger voice? And Ron alluded to this. We need to organize. We need to have one voice or a bigger voice. For some reason, we are ignored. Trust me, I've been in this field for now well over a decade and a half. I fight every single day to get attention. I think we all know that. Why is that? I think it's very simple. It's ageism. We're not particularly fond of older folks. We don't see them as part of our society. We want them to go away. And we have to change that. I think this is a stigma that affects all of us. And COVID showed this very clearly. In the beginning, if you recall, it was people who were old who were at risk for this virus. Not true. It's not their chronological age. It's their medical condition. Clearly, as you get older, there are more medical conditions associated with the person, but it was really age. Age drove a lot of the fears and still myths in this epidemic. It's a good old classic ageism. Okay? And I think that we need to be aware of it to begin with, and then combat it from where we sit, not only as researchers, but directors of programs, et cetera. It is toxic. It is as toxic as AIDS stigma is to all of us. And lastly, I said this in the beginning, we need to listen. I think Ron had a great listening sessions across this country. We need to listen carefully to what our clients tell us. And there is no one size fits all. For example, social isolation. Social isolation actually has served this population well. They were already socially distancing to begin with, which is probably why they have fewer infections with COVID. But how you change social isolation depends on the person, not on the place. You might have a sewing bee, you might have a bingo, you might have a trip to whatever, to an event that fits some people, but not all. Social isolation is a very, very, very powerful determinant of health outcomes and of health behaviors. And it's not easy. Talk to people in the aging world and they'll tell you that. We need to provide programs that are good for everyone and not just, for individuals and not for an entire group. That's just not going to happen. It's really the challenges of HIV and aging these days. Gerontologists know this well, that as we age, the person becomes far more individualized. You know, when you're young or look in the womb and you look at a fetus developing, we all look the same. Teenagers, we all look the same. But as we age, we all age differently. And we have to be aware of that individuality, which is even more so as we age. You know, if you want to know about ageism, think about the last time you went to a funeral and you were an open casket and someone said, well, he looked fabulous, right? She looked great. No, they don't. No, they don't. That's ageism. We have to stop that. We have to accept people for where they are in their life, meet them where they are, and ignore their age, okay? If someone says, oh, 50 years old, you know, 50 years old chronologically means very little. We all know this. Some people age better than others in the sense of getting up into the 8th, 9th decade of life. Others don't even see beyond the 50th.
I hear you, even. I've got to call a little bit of time on there, but I hear exactly what you're saying. I remember in a conversation with someone, I think it was Gil Noble at one time, we were talking about the difference in how slow things have changed from the end of slavery to now in terms of racial justice and how we've changed around income inequality and how we're dealing with ableism and all of those kinds of things. And he literally said, you know, and this was when it was actually 150 years from emancipation. And he says, well, you know, 150 years is only a pimple on the ass of time. So if you think about what 50 years or 55 years is, it's, you know, it's a teeny blackhead at this point. So I want to thank you for not just bringing us a lot of real powerful experience, not just in the years, but also in the depth of your proximity to the population, to the people, to the issues, and to the lived experience. And you were talking specifically about isolation and about these critical, not just the anxiety of it, but really the loneliness and isolation being one of the bigger challenges, even bigger than the virus itself. And someone had posed a question around the collaboration of how, in terms of our people living with HIV, especially in this imposed isolation time, are we partnering up more with area agencies that focus specifically in on older people or aging populations and elderly groups of folks, and how that unique experience in the HIV world or in the LGBTQ space are issues that are working across collaboration in terms of the older population affected by HIV and now facing some of the anxieties around COVID. What's that collaborations world looking like?
Well, at the moment, I think it's kind of non-existent. I think we have to reach out. As Ron said, we actually have to mainstream. When we finished our study back in 2005, that was one of the recommendations of the policy folks, that we need to mainstream, because AIDS service organization can't do it all. We're never put in a position to do that. We need to hold hands with our partners in this and listen to them and see what we can learn.
Yeah, and there were other concerns around the housing as well. So thank you. And we'll come back to that. We'll have a little bit of time for conversation because there's some more questions that are coming through in the Q&A section. But thank you so much, Stephen. We're going to move forward to our sister Venita Ray. Venita, if you would, please go ahead and take the mic, and then we will come back in and have a panel discussion with some of these questions and comments that are coming in. And thank you all again for sticking with us through this really incredible conversation. Venita, take it away.
Hey, thanks, Dazon. Are you guys hearing me? Yes?
Very beautifully, yes.
Okay, so as I was listening to everyone, it really hit me how much of an honor it is to be sitting in this space, sharing my lived experience, and with the privilege of aging and being an older adult living with HIV, because everybody living with HIV didn't get this privilege. And so I want to really acknowledge that there are so many folks around the country that are doing this work every day. The Reunion Project, Kick Ass, I mean, just all kinds of folks who are doing this work. And I'm kind of here just to share my lived experience as a woman living with HIV, a Black woman in the time of COVID and everything else, and I live in the South. As I'm sitting here, I'm also remembering, as you were talking, in our community here in Houston, we just had an older gentleman pass away, transition in the last 2 weeks, alone in his apartment, living with HIV, a retired gentleman, Melvin. And, you know, it hit me right in the gut as I was sitting here waiting to speak. And then I remember we've had a few deaths like that of older folks in our small kind of community here. And then one during Hurricane Harvey, a real gentleman, a retired school teacher who was still living in shame of folks knowing he had HIV, and he passed away by himself during Hurricane Harvey in his apartment. So, and I'm still crushed when I think of Greg, because, you know, we talk about aging with HIV, like still HIV is not stigmatized, and people living, older people living with it are not living in stigma and shame, and they are. And that that just increases the loneliness, the isolation, and everything else that they're going through of aging with HIV, which is a privilege, but the quality of life and the real circumstances don't always show that. So for me, I'm a woman who was diagnosed in my 40s, now in my 60s. And I remember as I was beginning to get older and dealing with hot flash and other issues, I was researching all kinds of stuff, trying to find issues on what menopause looks like for a woman living with HIV. How does it interplay with medication and all that? And couldn't find any information about that. And really being frustrated about, you know, the impact of hormones and menopause, not finding even my doctor talking to me about being sexually active, what does that look like, or even just sexual health information. So I never expected to be over 60 living with HIV and really knowing how to navigate all of the stuff that comes with being this Black woman living with HIV as a grandmother. How do you talk with your kids about, oh yeah, your grandmother's living with HIV, so all of those things you are hearing, let me talk to you about it, because those are not easy conversations. With my diagnosis came a 4-year depression and darkness that I had to process through and to come to terms with that. And so sharing it with family, there was a lot of mental health components to this that a lot of us still deal with today, the stigma and shame, and how do you explain, to older partners, in the older HIV community, I don't see HIV talked about a lot. And so it is something that is still heavily stigmatized and heavily kept in the closet. I know a woman today who was diagnosed when her kids were small. They are grown and still do not know their mother lives with HIV, and she is now retired. So there are a lot of women over 50, and we know Black women represent 60% of all women living with HIV and are dealing with these intersections of race, gender, poverty, class, and everything that comes with it, and still living in a level of secrecy and shame. I think we need to really think about and redefine what care means and what being healthy means for an older person living with HIV. I remember one visit I went to, I saw the sheet after I left my doctor, and it said something about advised to have safe sex. Well, we didn't even have a conversation about sex. And I had to call them back and say, if you want to talk to me about it, we can, but you won't put things in my record that don't reflect the conversation we had, because those are the things I know to talk about, but we don't talk about my sexual health, and I'd like to talk about that. A lot of us, and including myself, didn't expect to live this long. So there are financial and economic kind of considerations that we have to talk about and have to be facing now that, I'm in the 60s and I'm working and doing what I do. I think we also need to lift up the importance of networks of people living with HIV as potential sources of to deal with social isolation, mental health, and all of those kinds of issues. Here in Houston, we have a group called HIV and Aging that do a Christmas party for those folks that are isolated, a holiday party, should I say. And it's only one event that's done around that folks get to come out and be entertained or mix. That is not good. I mean, just isolation in and of itself and mental health issues has a bearing on my health. What I also know, when COVID came out, that, I remember the first thing was, if you're older and immunocompromised, well, I felt like a target was on my back. And then the more conversation, if you're Black, well, here I go again. And then racism, which permeates all through the HIV epidemic that we don't talk about enough, even though we say the majority of Black folks are the ones diagnosed with HIV, but the conversation about race typically ends there. And so we don't really take a look at the mental health stress and trauma and PTSD of daily living with HIV in a COVID era, and in the era we're living in now of anti-Blackness, anti-Black racism, and police violence. And so I remember saying, oh God, I'm the person they're talking about. And my daughter said, but Mom, I don't think of you as your immune system is compromised. You're healthy. Then I had a 12-year-old niece say, but Auntie, they're talking about people over 60. Well, I meet all of those, but it was great to hear that my family saw me differently, which allowed me to think differently. So I want us to think beyond just saying to not live in fear and anxiety is one thing. To actually do it and get the support and care necessary to do it is something different. I don't think my providers and most healthcare folks really understand the additional stresses that it takes to live with HIV, being Black, living in this age, this era, with COVID with HIV criminalization, COVID, we're entering into a kind of new era where we're seeing criminalization happening there, the language that's used, that every day it can feel like an assault on your senses just to get up and try to, function without fear and anxiety in this current moment. So I think you have to look at this moment in the totality of everything people are living with, and it's bigger than just our healthcare, but it really needs to consider all of those things that everybody has talked about in terms of, you know, needing that support, dealing with mental health. We're not just trying to take a bunch of pills. That is not the answer. We need better support, and we need folks to understand that it is a continuum of stuff that we have to deal with that impacts our health and our ability to stay healthy. For me, I've had to readjust, even in the COVID era, what self-care means to me, which means limiting news, social media, you know, and trying to focus very differently. But I'm really privileged. I get to work from home. I have health insurance. I have a lot of things that are at my fingertips and resources that others don't have. And so I think redefining what care looks like, what the thriving looks like, and really considering the kinds of conditions that we live in that are not, I don't say doom and gloom, but we need to consider them when we think about getting older, living, aging, thriving with HIV, and in a COVID area, and in a anti-Blackness, racist kind of era that is not new, mind you, but definitely needs to be talked about in the HIV context as well. So I'll close here and say thank you all.
Wow, what an extremely powerful, comprehensive, and really interconnected panel discussion we've had. And I want to acknowledge all of the folks who have been putting their questions in the Q&A, as well as in the chat box. And we'll get to several of those. So if you all don't mind, for the panelists, you can go ahead and open yourselves up, because let's have a conversation, a panel conversation here, and start back up with Ron. Someone had a specific question for you, and folks can actually chime in. You can talk about this together if you want. But when you were talking about community anxiety, I know that Stephen went in a lot deeper on that. There have been a couple of other questions in the chat box about this. But how specifically are we defining what community anxiety is? And give an example of what that looks like. What have you observed when we're talking about, from this topic, what community anxiety actually is?
Thank you, Dazon, and thanks to the participant who raised that question, because I think it's really something that needs to be focused on. I think community anxiety for me is sort of the collective feelings of individuals, particularly those living with HIV and older adults living with HIV, have about what does COVID-19 mean for me? Where do I get accurate information? Am I more vulnerable because I'm older? Am I more vulnerable because I have HIV? I've been cut off from my care providers, cut off from support. I think those are the elements that collectively make up what I and many on the panelists are describing as that community anxiety. And I think some of the action steps that can and perhaps should be taken, we certainly need more information getting out. There was a question or a comment in the chat box about really what is it true, or that being HIV positive does not make you more vulnerable to COVID-19. And to the best of our knowledge so far, that's the case. But also, there is the impact of comorbidities and social determinants that increase the vulnerability. So those are the things that have to be taken into consideration. And that almost paradox or balance between, I'm not more vulnerable because I'm HIV, but have HIV, but I am more vulnerable because of racism or because of my cardiovascular disease. So having information as accurate as what the science allows us, and getting that information out, I think is one of the action steps that we can take now to address community anxiety. And Zoom meetings, getting people together. And this is something that the various AIDS organizations and providers in the communities can really take a concentrated look at Zoom sessions that specifically address older adults living with HIV and specifically include the information that can lower anxiety and promote self-efficacy.
Can I make a comment here, Dazon? You're on mute. Yeah, we're not hearing you.
I would say jump in, Carole.
Okay, so, you know, I just want to really acknowledge how important this webinar is today, because when we talk about community anxiety, you know, anxiety is based in fear, and unfortunately right now in a lot of our communities, that fear is being exacerbated by false information or old information. And so the more of these kinds of things that we can have that are accessible, and not only by technology, but by also presenters who are accessible, you know, to really kind of level the playing field about what knowledge we know, and to remind people that knowledge is continually evolving, right? And that we have to be comfortable with that, right? And that we have to be comfortable that we're growing and learning more each month. And that doesn't mean that somebody was lying a couple months ago. It just means that we're learning more and to put things into perspective. So I really think this kind of webinar and more of these are really great. And then also, you know, again, going back to, I know it can sound a little trite, but going back to that personal self-care of keeping a routine, getting out, getting some sunshine, you know, get away from social media. I think you may have said that, Venita, that, you know, social media is so anxiety producing, right? There's so much, and media in itself, that's what it does. It hypes people up, right? So you look in the next day, you know, and really just thinking about how are some ways to bring that anxiety down a little. Some of it is community-wide and some of it is on the individual level, myself included, right? All of us included, I bet, right? Can't hear you.
So it appears that Dazon's having some technical difficulties. So this is Whitney Thomas with AIDS United. So I'm going to jump in and assist.
Okay.
How about now?
You're back.
Sweet.
Okay, sorry about that, Whitney. But if you had something to say, go right ahead. What I was going to follow up on is that other level of anxiety is just what you were just talking about, Ronald, and also Carole, you were coming in when talking about social media. Cordella asks in the question and answer section about the telehealth services, and I'm wondering how much of this need to pivot so quickly and so robustly and so consistently in the electronic world and in the virtual world, how much of that do you think is also driving some of that anxiety, especially for folks like, I'm a Gen Xer, but I consider myself a little less analog than I was 5 years ago. And my mother, you know, she'll be 80 in a few months, and she has really worked herself to transition into a more technological world, and comes with all of that. But she has a grandchild that she has had incentive to learn, because, you know, all you need is to put all this stuff in a 6-year-old hand and you can go to town. So talk a little bit about how a lot of this technology in and of itself, a new world of telemedicine and distancing, especially in the era of COVID, may be contributing to some of that anxiety. And to follow on with that, what are some of the resources that are out there to help those organizations that are working and striving to meet the needs in the new distancing, electronically communicating world of care and treatment and support?
I just want to highlight one thing that Tez Anderson said, and I'm going to, you know, steal his thunder. We, in addition to trying to build up technology and how, you know, people either have access or comfortable levels with it, we also have to go back to some of the basics. You know, that simple phone call. And you know, he talks about making a point of every day calling somebody he means to get in touch with. You know, we hear from our nurses who are making phone calls every day just to touch base with somebody, right? So not only how do we learn, get people get across that digital divide, but also let's reinforce some of the things that we know that work from the past, right?
Mm-hmm. Mm-hmm.
Dazon, can I add a point also
Yes,
about
please.
that, to that question? I think, because I think it's a good one because I know I have been numerous times been technologically challenged. So I think, and it may be sort of a contradiction, but I would invite aid service organizations in the communities to put on a session of how to access the services, how to use Zoom, how to do this, how to do that. And as I said, it may assume a minimal level of equipment and knowledge, but helping people to navigate and recognizing that there are those problems. Because too often we set up these Zoom meetings and WebEx and everything, assuming that everyone knows how to do them. And we need to find creative ways to just do, and I may be aging myself, to have Zoom or telehealth for dummies approach and some tutorials that will help people deal with this new technological world that we've just been thrown into all at once.
How about we call it, you know, new training for the analog set. So, but there's a very interesting question. Yes, please go ahead, Venita.
I just want to say one of the things we're discovering too is that we're trying to get funds to help people get internet to be able to Zoom, you know, but everybody doesn't have the level of internet or access that they can even access sometimes to get on some of these platforms. So, and how that is playing out in social isolation. So YouTube channels, you know, just there's a variety of ways that we need to also think about.
I mean, it certainly is a new apartheid, if you will, between the urban and rural experience online. There's a lot less access. And I was recently in another kind of meeting where it was actually a national board meeting where we had one board member who lives on the res who, no matter what you tried to do, there was extremely limited internet and Wi-Fi access for her unless she traveled 200 miles, you know, into an urban city off the reservation just to participate in, you know, a board call. So these are real issues. And one of the, you were talking about resources for that. One of the questions that's come in through the chat is, has there been a marked increase, or have you seen a marked increase in Ryan White funding that's being targeted towards the HIV population that is older, since it is 60+% of current people living with HIV? Do we anticipate that there's possibility of even a line item in planning council budgets to address some of these issues that older people living with HIV might need? I mean, linguistics, for example, is a service that's allowable under Ryan White. How does that associate now? Luckily and beautifully, we have language interpretation here today, but how are we making sure that that's available resources through Ryan White funding? Is that something possible, or is that something already happening in different jurisdictions? Anybody can take that. Stephen, you got that one?
Yeah, well, I must say, look how quickly we all adapted to Zoom. Many of us didn't hear about Zoom until 3 months ago, so it can be done, and I don't think that there's any young ones here at the moment. I might mention that we have probably the most comprehensive resource site on HIV and aging, www.aginghiv.org. And most of the information that's there is derived from the American Academy of HIV Medicine. So it's very valid information. Please visit the site. There's a great deal you'll discover, and there's a lot of interactive opportunities, particularly for local organizations. I think, you know, information is power. And this is not a simple domain, but we need, the more you learn, the more you realize, one, I don't know. And as was mentioned before, this is a moving target. Aging is a dynamic process, and to think that everything kind of stops on a square is a misconception.
Absolutely.
And,
Anyone else?
Dazon, to the Ryan White question, I think this is one of the issues where an example of the need for the kind of sustained advocacy that I spoke about earlier. I mean, I don't think there are enough targeted funds for these type of programs, even within the Ryan White program. I think there is some there is enough flexibility to start them, but I do think that, and using the example of a line item or guidance from HRSA that specifically instructs, and I'll use that word deliberately, instructs local planning groups to include programs that target and serve older adults with HIV. So I think there's a lot of advocacy work within the Ryan White program that is needed to get those kinds of support services.
Excellent. I'm going to pivot just for a moment to some more direct to the clinical questions that we have coming in. One person was specifically asking about the testing for COVID. Were there any particular concerns that do we have any new news around the antibody testing, the accuracy of that? And even a second question really is around the fear of getting COVID and being offered remdesivir, for example, as an antiretroviral, and what do we know about what that might be in terms of an impact on their HIV antiretroviral therapies? Do we have any insights on that? I know, Carole, you said that the new news is every week around what we're learning about the COVID response, and in terms of the biological, biomedical, and clinical response. Do you have some insights on those two questions?
It's funny because I was just typing the answer to that person in the box, and I
fantastic!
I couldn't get it to post. I was like, yeah, okay. So first on antibodies.
Help.
So yeah, I need help, right? So first on antibodies. And again, you know, if we compare this to HIV, we have to realize that the knowledge that we have on HIV was, you know, developed over 30 years, primarily from the NIAID under the direction of Dr. Tony Fauci, right? And what we're doing now is looking at things that are being known. Granted, a lot of it is based on knowledge that was ascertained through all those years in HIV, but we're looking at things that are being known in 4 months, right? So again, this constant churn of new information. But what we know about antibodies right now is a lot of uncertainty, right? So even if you do have a positive antibody test, what does that mean is the big question. Are those antibodies effective? And for how long do they last? And of course, those kinds of things take time, right? Because how that normally works is when you have somebody with antibodies, you track them over time and see, you know, how long does that protection last? And we don't have that right now, right? Is it going to last for a couple months, a couple of years? We don't know. And even does the present. So now what they're looking at in labs is you know, taking those antibodies from humans and looking in the lab and interjecting that sample with the virus to see how does the cells react. But again, that's how the cells react, right? Which is, again, different from the human response. So we don't know right now what the value of current antibody testing is, because we don't know the value of antibodies at this point, right? And it's really interesting when you think about this compared to HIV, because with HIV, we knew about antibodies first, and it took years till we got antigen testing. And now it's the opposite here, right? Where the COVID testing is antigen testing up front, the swabs, and then the antibodies are less known. So that's a difference. But I would say that by the rate things are going, we'll have more information, you know, soon, but we just don't know that now. So even people who test antibody positive, I guess it's a relief, but we don't know what that means. We don't know if you're protected or not, and if you are protected, for how long. Remdesivir.
Just got a couple of minutes, so thank you.
So
go ahead, Carole.
Real quick, there's no information known about interactions between HIV meds and remdesivir. One good thing, though, is the remdesivir trials were primarily conducted through the HIV research networks and through the CFARs.
Yes.
A lot of HIV researchers were the ones who did the remdesivir trials. The patients were not HIV, right? Because you have a very small number of people with HIV with COVID. But of course, those researchers were aware of that. So my sense is that at this point, we don't know if there's any interaction. There doesn't, I couldn't imagine that there would be. I can't imagine there would be.
Great, thank you.
Yeah.
So we've only got a few minutes before I turn this over to Ronald to close us out, to give people some final thoughts. Right now, I've got about 3 minutes for you to do so. So if each of you would take about 30 seconds, I mean that because I do radio, so I really mean that. So about 30 to 45 seconds to just give us your final thought based on some of the questions, some of the other comments you've heard from the other presenters. if you would just give us your closing commentary. And Jesse, am I turning it over to you for the closing commentary, or is it, I thought it, yes, that's a yes. So, because I had the note on Ronald. So before I turn this over for y'all's finals, I want to say thank you for entrusting me to lead this conversation. I want to give shouts out to everyone who has chimed in: David, Melanie, Alberto, Elliot, Larry, Robert ×2, Tyler, Bonnie, Cordella, Raymond, and Joshua. Thank you all. There were some others that came on in, Jacqueline, I believe, with your comments. So thank you so very much for your active participation in this conversation. And it's been my pleasure to learn so much from you all today. Jesse, take it away to lead us through these closing remarks and to close us out. Thank you.
Well, thank you, Dazon, and thank you as always for your magnificent moderating, which was not moderate, but exceptional. And thank you to Stephen and Ronald and Venita and Carole for bringing such not only important information, but impassioned information. Your commitment to all of us who are aging with HIV, and all of us with HIV are aging, and we're navigating this new COVID-19 world. We hope that our Resilienc webinar series, Relief, Recovery, and Resilience, is bringing you information that you can use. I know that I took lots of notes today and learned a lot of things. And some of the issues that I'm facing as a person aging with HIV have been articulated well today. You know, I'm dealing with polypharmacy issues right now today with calls that I've had to make between sessions. So these issues are ones that are very much part of our lives, but we are also part of the solution. And that's why relief, recovery, and resilience is a framework for all of us for how we can address living with HIV, aging with HIV, and being HIV service providers in a world of COVID-19. Thank you all so much for participating today. Thank you all for participating not only with the questions, but participating with all of us in building the solutions for our community. Thank you all, and on behalf of AIDS United, thank you and have a great evening.
Bye, y'all.
Finished? Good.
Whitney, I did have one more question about the follow-up with regard to questions that we might not have gotten to people